Case of man with dirty fingers. This picture represents our patient. Man, 57 years old, with low socio-economical status, generally healthy, smoker, with pain continuing for 3 weeks. Pain is prominent in his right hand, and you see purple color of distal fingers. He is referred from local angiosurgery department to exclude rheumatological disease. Detailed anamnestic data from referral letter. Acute pain in right hand except right thumb. Professionally, he worked with vibration tools. Objective, livid color of distal fingers. Some of color change is due dirty skin and black nail. There is a pain in fingers on palpation except right thumb. No restriction of movement of fingers. Pulsation of brachial, ulnar and radial artery is normal. Conclusion: no arterial disease is present in my opinion. Please assess and exclude rheumatological disease. Segmental systolic pressure measurement. There is a R record of measurement of systolic pressure. You can see the normal symmetric systolic pressure to the area above wrist. In the area of fingers is zero pressure of finger 2nd, 3rd and 4th and 5th. You see that thumb's pressure 60 mm represents normal blood pressure which we can expect in this area. Low pressure is actually present on both hands. You can see that thumb pressure represents normal blood pressure we can expect in this area. Low pressure is actually present on both hands, not only on the right hand, but even on the left hand. The patient admits lately that he has pain in the left side too, but it is tolerable and he is able to cope with it. Photoplethysmographic record of patient. On this slide you can see photoplethysmographic record, both thumbs and 3rd finger on both hands. We have a simple photoplethysmographic probe which allows us record flow of 4 fingers in same moment. In upper part there is a record of both thumbs. You are clearly able to see waveforms of pulse. This pulse is visualized with deflated finger cuff. You are able to recognize the oxygen saturation, which is normal. Lower part of image is representing the pulsation of 3rd finger on both sides. Waveform is now absent. You are able to see only flat line. As in previous case, no cuff is attached to finger. This represents complete loss of flow. Saturation of oxygen is now not detectable, and this is of course a result of critical ischemia of finger. A workup of this patient. Patient was urgently referred to the tertiary specialized angiology center with probable diagnosis of critical ischemia of both hands, at this moment unknown origin as a result of our segmental pressure measurement. The next investigation methods were performed. Ultrasound has shown normal flow in left arm from subclavian artery to the proximal part of palmar arch. Due pain in right arm, they have not been able to perform ultrasound examination. My note is that this result again shows that ultrasound is not always best option for diagnosis of occlusion. The finger arteries are very difficult to visualize, and arteries above wrist were completely normal. An angiography examination finally proved bilateral complete occlusion of arteries in hand, except both thumbs. The following investigation revealed lung small cell carcinoma, and patient dies in 6 months. In conclusion, you see that the ultrasound lacks ability of detecting flow in area distally to wrist, and we would recommend segmental pressure measurement in case of any suspicion to the artery pathology. We were surprised how significant were photoplethysmographic findings on left side, which was less affected, and patients have been almost reluctant to the pain in left hand. Regardless, complete occlusion of arteries in hand. This case represents atypical Raynaud syndrome. Young lady was referred to us for pain in her right arm. She was smoker with no contraceptives, which presents in our clinic with 6 months pain in her right arm. The pain starts in a little finger. Lately, in a few months, develops mild Raynaud syndrome. She was repeatedly seen in orthopedic and neurologic department. Previous diagnosis was carpal tunnel syndrome and epicondylitis. By objective examination, we haven't been able to find anything pathological, and the hand looked completely normal, so normal that we haven't taken any photographic record, which could prove the difficulties in diagnosis of arterial ischemia. Segmental arterial pressure was performed in our patient, and right brachial artery has shown 60 mm Hg, which was 50 mm lower than was measured on the left arm. Normally we can accept differences only up to 20 mm of Hg pressure in healthy patient. 0 mm Hg in a right radial artery was seen in comparison to the left side, which had pressure 110 mm. Zero pressure was again seen on the fingers of right side in comparison to healthy 90 mm of Hg on the left side. We referred the patient urgently to the angiology center. Ultrasound confirmed occlusion of brachial artery. Angiography confirmed massive occlusion distally to subclavial artery, and transthoracic echocardiography made the diagnosis of foramen ovale persistence. The conclusion of this patient is very interesting. The patient had massive embolization of brachial artery due foramen ovale persistence. Advice: there is a plan for catheter-based closure of patent foramen ovale. Laboratory method in diagnosis of arterial ischemia. All previous methods, it means functional examination of arteries with measuring systolic blood pressure and capillaroscope of fingernail bed, were able to demonstrate integrity of arterial wall. But intact arterial wall represents only one part of possible pathology in case of ischemia. Any occlusion could be associated with rheological quality of blood in vessels. So, in examination of arterial problems, we shouldn't forget to check the biochemical parameters of blood. In our clinic, we are taking blood for analysis of basic blood tests, full blood count, liver function tests, urinalysis, ESR, and as a representative of coagulation parameters, quick APPT, anticardiolipin antibodies, beta-2 glycoprotein, ANCA antibodies, and we should be able, with the help of laboratory investigation, exclude the presence of atypical proteins causing problem in cold in form of cold agglutinin and cryoglobulins and cryoproteins. During laboratory screening, we shouldn't forget about rare atypical proteins which are present in blood and could cause in freezing condition clotting of the blood in the form of Raynaud syndrome, and these proteins are called cryoglobulins. Cryoglobulins and cryoproteins are atypical proteins which are precipitating in cold condition. In real life, This most cold area is area of hand and foot fingers. This is probably explanation for typical flare-ups of gouty arthritis in thumbs, because crystallization of MSU crystals is again associated with low temperature. In case of precipitation of proteins, blood flow will slow and typical Raynaud syndrome will appear. This is long time known fact, and we should always carefully look for cryoglobulins. Not all clinicians have access to the laboratory department with appropriate equipment. Solution is very easy. You are able to detect the cryoglobulins yourself with very simple equipment. If you understand the principle of testing, you will be surprised how simple is detection of cryoglobulins. Cryoglobulins are seen very easily in serum, which is stored for 1 week in a refrigerator. You are able to recognize the difference of serum with cryoglobulins and serum without cryoglobulins. Unfortunately, during blood processing, which is done in a way of simple centrifugation and removing erythrocytes from tube, will be cryoglobulins precipitating in removed erythrocytes, and serum will be cryoglobulin free. How is possible to avoid this loss of cryoglobulins? Our answer is simple. The blood tube must be immediately incubated in 37 degrees of Celsius to let separate erythrocytes and serum. The same temperature must be present during centrifugation. You could buy very expensive centrifuge with the stable temperature ability, or put the cheap standard centrifuge in box with controlled temperature. This box could be constructed on DIY basis. Our product is presented in picture. You see the cryoglobulin box, centrifuge, and preheated syringes and tubes inside the box. Indication of vascular examination. There is no simple indication of vascular examination. The symptoms are not always associated with severity of vascular pathology. Symptoms of pain, heavy legs, pain in lumbar area, cold feet are very often misdiagnosed as a neurological or surgical diagnosis. From our experience, we suggest thorough and complete screening for vascular pathology in any case which is represented as a Raynaud syndrome, cold feet, dull, atypical pain in lower back irradiating to hips or legs, in which we can exclude any clear non-vascular pathology, any claudication, skin ulcers, and suspicion of vascular changes, and don't forget about arterial pathology, which could be part of venous ulcers. Anamnestic data, which will increase suspicion about vascular pathology and make the vascular examination almost mandatory, represents diabetes mellitus, smoking, cardiovascular diseases as a ischemic heart disease, transitory ischemic attack in the brain, inflammatory rheumatic diseases as a scleroderma, rheumatoid arthritis or lupus, chronic kidney disease, and family anamnesis of early vascular disease. Raynaud syndrome with laboratory findings of monoclonal gammopathy, positivity of rheumatoid factor, erythrocyturia, and elevation of ESR, and cold sensitivity should be always assessed for cryoglobulins. Summary. With the help of simple devices, you are able to very easily make diagnosis of arterial diseases, pressure cuff of different size, tonometer, photoplethysmographic probe, magnifying glass in form of capillaroscope or stereomicroscope, and cryobox represents essential instruments which will help us in outpatient clinic diagnose and check arterial system. Functional arterial examination with segmental pressure measurement is key to fast, effective diagnosis. We hope that our recommendation helps you establish optimal service for your patients.